We just came from a press conference where there was discussion about legislation to try to, for example, get rid of additives to food on a state level. You've told me earlier today that in places like Europe, they simply don't have these kind of additives. So I would love if you would share if there is a plan to sort of get it from the top down, to speak to the food companies and say, how can we get it out of the food so that we don't have to go state by state by state and get it out through legislation?
I mean, you know, one of the first groups I met with when I came in, when I was, after I was sworn in, were the big food companies, all of the major food processors and producers in this country.
How'd that go?
And it went very well. And I think they're at the point where they see the writing on the wall. And, you know, one of the things I said is that the food dyes are kind of the most egregious because they don't use them in any other country. They're clearly associated with a variety, a grim inventory of diseases, including cancers and behavioral diseases, neurological diseases like ADHD. And it's very, very well documented. And they're making, in many cases, the same products in this country that have those dyes, and then they use vegetable dyes in Canada, Mexico, and Europe.
So can't you say to them, hey, we want the stuff you're making there?
Yeah, that's what I said to them. And you know, there was no real pushback. It was just about timing. They said, it's going to take us a while. For example, the CEO of Pepsi, which owns Doritos, said that in Doritos, you know, people, the consumers like them to be very red, and we have not yet found a vegetable dye that we can match, but we're going to do it. And I said they all have to be out within 2 years. Within 2
years. You said it's going to take a while. What's a while?
Well, I think we can go much faster than that. And I met with Tyson's Foods 2 weeks ago. And they only use one dye. They're down to one dye, which is a caramel that is used in some of the meat products. And they said, we're already working on a way to get it out very quickly.
So are there other things you can let us in on that haven't been publicly announced yet that's happening in the background?
Well, you know, we're getting rid of the GRAS standard, which is kind of the biggest villain.
Which stands for
generally recognized as safe. And it was in the 1940s and 50s. FDA adopted this standard and started testing chemicals in food. Initially, FDA was a response to adulterated foods, so it was testing for bacteria in foods. Then it began regulating chemical content of food and chemical additives. And it didn't want to, it wanted to draw a line where it didn't have to test everything, so that traditional ingredients like yeast and wheat and eggs, et cetera, they said for those kind of foods, we're going to adopt a standard called generally recognized as safe. We don't have to test them. And we're not going to make the companies test them. But the FDA became captured by the food industry. And they enlarged the GRAS standard to apply to everything. And that's why we have 10,000 ingredients in our food. And the Europeans only have 400 in theirs, because in Europe, before you add something, a chemical to a food, you got to prove that it's safe. In our country, it is rubber stamped. Everything is assumed to be safe.
So it's the precautionary principle.
It's the precautionary principle, which is, you know, you keep it out until you prove it's safe.
I have to turn to the news of the day, since we have you here. A second child in Texas has died from measles. Why are Americans dying from measles in 2025?
Well, there's only 3 deaths from measles in 20 years. And they're all people with extreme complications. And
that's how you die from measles, because of the complications of it.
Yeah, it's people who are already sick. And
but there was no evidence with for example, the two children that they were sick before, and they got sick from the measles, right?
Well, no. Daisy Hildebrand, whose funeral I attended this week, was hospitalized 3 times from other illnesses. She had extreme tonsillectomy. She had mononucleosis that she could not kick. And then she got measles. She got over the measles, according to her parents. And according to the medical reports, I saw a report on it today, that the thing that killed her was not the measles, but it was a bacteriological infection.
Of her lungs?
She was graft positive for strep bacteria in her bloodstream.
Right. But what kills you with measles, of course, is you have the measles virus.
You have measles and you get pulmonary illness.
Yeah, you get pneumonia, and because the measles damages the lungs, and then the bacteria get in, and that's the secondary infection. But it's the measles. But you came out.
So you know what? We do a pretty good job. We do a very good job at controlling the measles in this country. And although the numbers of measles cases are now around 640. Those numbers will continue to grow because you're adding old cases to new cases.
And there's a long incubation period of 10 to 14 days, so you don't know who's out there spreading.
Well, no, but you're counting all the old cases where people have already got.
But there are also people infected today who are traveling, and you don't know who they're infecting, right?
But the point I'm making is that the rate of increase has substantially decreased. So we are successfully controlling it.
I mean,
I'll compare it to Europe, where they've had now 127,000 measles cases compared to 840 here, and they've had 37 deaths. So you ask, why are we still having measles? We're having measles we're always going to have measles, no matter what happens. As the vaccine wanes very quickly.
But I guess the issue here is, and I'm sorry for interrupting you, the issue was like a couple of days ago, you did come out and said, and why don't you tell what your statement was about measles vaccine? Because I was interested to read that when you tweeted that.
Measles vaccines limit the spread.
Mm-hmm. Well, you said it was the most effective way
to limit the spread. But yeah, with President Trump's position and my position is there's people who do not want to get vaccinated, and that's their choice.
Right.
And we ought to be able to treat them. And we ought to know how to treat them, and doctors ought to have the best information how to treat them.
Understood.
And we're focusing on that.
But prevention, of course, is better.
We encourage people to get the vaccine.
Right.
Because it does limit the spread.
Right. And it prevents it, right? It's preventing the illness. 2 doses, 97% effective. And you said that.
Yeah.
2 Louisiana babies have died of pertussis. That prompted Senator Cassidy to tweet, and I'm reading this because I want to get it exactly right. No child in Louisiana should die from a vaccine-preventable disease. Please protect your child with a vaccine. Would you consider making a similar statement?
Well, the pertussis vaccine is,
No, he's just saying about a vaccine. Just would you consider making a statement saying, please protect your child with a vaccine, even if you want to say specifically the measles vaccine, and because there is a measles.
Well, I would say definitely so for the measles vaccine.
Because you see where I'm getting at, right?
We need good science on all the vaccines. There are some vaccines, like the pertussis vaccine, that don't prevent transmission, and there are. That in some ways can be dangerous too, because what can happen is that people do not become symptomatic, and yet they're capable of spreading it.
I understand that. It's one thing, though. I'm so sorry to interrupt, but I know we have like 20 minutes, and I want to just make sure I get through, and I want to get back to food. It's one thing to say the measles vaccine is the best way of preventing spread, but it's another thing to then say, and therefore, we suggest that you get the measles vaccine.
We encourage people to get the measles vaccine.
Okay, so I think that's actually the next step, and that's news as far as I'm concerned that you're saying that, because there's the issue of the federal government. We talked about this earlier when we were talking about food. That what's the position philosophically of the federal government in terms of public health?
The federal government's position, my position is people should get the measles vaccine, but the government should not be mandating.
Understand when there's not, and the same thing we talked about food.
I've always said during my campaign and every public statement I've made, I'm not going to take people's vaccines away from them. Right. What I'm going to do is make sure that we have good science so that people can make an informed choice, and we are doing that science today, so that we know the risks of that product, and we also know what the benefits are. And right now, we don't know the risks of many of these products because they're not safety tested.
And I understand that position, but just to be clear, you are saying, and we do on the federal level, and you personally do recommend that people get the measles vaccine.
And when I say they're not safety tested, what I mean is they're not adequately. Many of the vaccines are tested for only 3 or 4 days with no placebo group.
I want to move forward because I know time is ticking, and thank you for even giving us this time. But I don't want to leave the subject without saying you just went to the funeral of a young girl who died from measles, Daisy, right? What was that like for you?
It was very heartbreaking. It's a community that's lost 2 children over a very, very short period of time to a 6-year-old girl, Kaylee Fair, and the 8-year-old girl, Daisy Hildebrand. And, I've spent a lot of time with both parents, both sets of parents. And it was, in some ways, it was very nice to be able to actually meet them in person and spend a whole day with them and share their lives with them and get to know their community, which was very welcoming and loving towards me, and to attend these very, very moving services for these girls and to meet people, these extraordinary people who are so resilient and so God-fearing and resourceful and just kind.
Did you?
And you saw a community. I mean, the Mennonite community was it was beautiful to me because I went to a large lunch with the whole community, and you had boys and girls sitting together, and nobody was on a cell phone. And they were talking to each other, and they were being part of a community. And it's, I think it's an ideal that the rest of us ought to be emulating.
As a physician, it's one thing to look at something that's going on across the country. It's another thing to be in the room where it's happening. And I wonder if you had any epiphanies, any revelations just to yourself as you were sitting there and listening to people and thinking about what had happened. Did it change you in any way?
It's always, it was a very moving day, and I just appreciated the welcome the community gave me, and I just appreciate the way that they live.
Let's move on to the last week's staff reductions and the coming reorganization. I think there are a lot of questions, and I've sort of been down in the trenches talking to people and hearing sort of the uncertainties. Between all of the resignations and retirements and the layoffs, the number of employees has been reduced by about 25%. Are things going according to plan?
Well, yes, they are going according to plan. And, our agency grew by 38% over the past 4 years.
Right.
So these reductions just bring it down to pre-COVID levels. And the agency, grew over the last 80 years or 70 years, and it grew in a way that's very unwieldy. We have 100 communication departments. We have 40 procurement departments. We have 40 IT departments. We have 9 HR departments, and many of them have computer systems that can't talk to each other, that are incompatible.
Or that are faxing to each other, right?
And then we also had 28 different institutes or 8 sub-agencies, and many of them were redundant. So what this reorganization is meant to do is to eliminate the redundancies, to streamline the agency, and to reorient it so that we are trying to make America healthy. Because a lot of times people, when they live in silos, become, their mission comes to accomplish a very, very narrow task.
I get it.
And I want everybody at that agency to wake up every morning like I do and say, what do I need to do today to make America healthy again, and to imbue them with and inspire them with that sense of mission. And we need to streamline the agency to do that.
Whenever you make such enormous changes, things are going to be disruptive.
Of course,
some things are not. Right, it's disruptive. So are things being disrupted, like, for example, monitoring food and drug safety or preparing for the next pandemic? Do you have a sense that that's being...
No.
You don't think so?
No. In almost every situation, the cuts we made were administrative cuts, and they were redundancies. In some cases, we cut programs, but we only did that when we consolidated them into another program. So the task will continue. Their mission will continue. The people are still there for the most part.
Although I guess things get lost in the sauce. But I was looking for examples. The Novavax COVID vaccine, and that's not an mRNA vaccine, was expected to be approved by the FDA, but there's a delay. Why is there a delay? Is it just personnel being shuffled around? Why is that?
We're looking at that vaccine, and it is a single antigen vaccine. And for respiratory illnesses, the single antigen vaccines have never worked.
So it's not because of lack of personnel or lack of people?
I mean,
okay.
We are actually shifting our priorities to multiple antigen vaccines, and NIH is already working on a number of those.
So that's the answer to that. I get that. Last week you said 20% of those fired were by mistake, and you knew that was going to happen. Do I have that right?
I didn't say that.
Okay, tell me what you said or meant to say.
Yeah, that was a statement that that Elon made at the beginning.
There was like an 80% and 20%. What do you mean to say so, for the record?
What Elon said to us at the beginning and in our cabinet meeting, and I think it made a lot of mistakes, it made a lot of sense, is that when you do, our government, we're spending $2 trillion more than we have each year. Mm-hmm. And that's existential, and that's a public health issue. And we need to cut the size of the government and make it more efficient and make it do services more efficiently. HHS's job is to make America healthy, and we're spending $1.9 trillion a year, and people are not getting healthy. People are getting sicker and sicker.
So along those lines...
So what Elon said is that when you do a disruption of this, a lot of times, 80% of the people that get cut, and my heart goes out to anybody who loses their job. It's heartbreaking for all of us. But it's something that has to be done if we're going to save our country and restore it. And he said that anytime you do a disruption like this, 80% of the people need to go. You may make mistakes as much as 20, and then you go back and remedy that and mitigate it.
So that brings up a question: what specific metrics is DOGE using to decide if a program is waste, fraud, or abuse?
Well, they have a very, very sophisticated group of people, and they have a very sophisticated systems for detecting fraud, waste, and abuse.
And yet 20% of the people who were cut, it turns out it was a mistake.
That was a hypothetical.
But a lot of people were fired and then rehired, right? So I just wonder, I'm just trying to imagine, and I've also, run a company in the past, wouldn't it have been better, or was thought given to, say, before firing them, going through and saying, what is that job? What is that job? Line by line by line, and saying, I think that person's job maybe isn't needed. This has to be eliminated.
That would have been another approach, and it's the approach that has failed for 60 years.
Because you mean it takes too long?
It takes too long, and you lose political momentum. You need to do.
But there are some casualties, the 20%.
Yeah, and there are going to be casualties, and there's going to be mistakes. And what our job is, as we reconstitute this agency, make sure that those mistakes are rectified.
Good, and we're moving along nicely. So I want to go to the cuts to research and programs. You propose more than $11 billion in cuts to local and state programs addressing things like infectious disease, mental health, addiction, and childhood vaccination. Did you personally approve those cuts?
I'm not familiar with those cuts. We'd have to go.
There's like more than 50 pages of cuts that I actually went through.
The cuts were mainly DEI cuts, which the president.
There were a lot, but I'll give you. I actually my eyes are blurry from going through them, and I understand because my eyes were blurry why you might not have seen every one of them, but for example, about 750. You talk about diabetes, adolescent diabetes, so important. About $750,000 of a University of Michigan grant into adolescent diabetes was cut. Did you know that?
I didn't know that, and that's something that we'll look at.
Yeah. So that's I wonder, should these be considered DOGE cuts?
Well, I couldn't speak to that, Dr. LaPook, because I'm not familiar with that particular study, but there's a number of studies that were cut that came to our attention and that did not deserve to be cut, and we reinstated them. Our purpose is not to reduce any level of scientific research that's important.
So that's I'm so glad you said that, because figuring out what's important is tough, right? Because you may not know at the time you're doing basic research what will end up being super important later on. For example, a discovery made in 1970 ended up leading to the monoclonal antibody therapy against COVID that helped save the life of President Trump 50 years later. So, if at the time he rolled into the emergency room, somebody said, I have an idea, let's have an antibody sop up the virus, it's way too late. You need decades of research. So how do you plan to ensure today's cuts won't mean decades in the future somebody will end up not getting the kind of care they could have had
Well,
if the research was done.
By that virtue, you should just fund everything, and hope for the best. That 50 years from now, that the discovery.
Well, no, but at least you go line item by line item and say, oh, diabetes research.
We're trying to target problems that we have in our society today that are very obvious, which is chronic disease, and we're trying to in infectious disease. And we're trying to target our cuts, or are targeting our funding, toward actually solving that problem. And we're reorienting, recalibrating our course. That we look at everything and say, is this designed to make? Is this likely to make America healthy? And you have to do that. Anybody who's funding research makes those decisions.
And it's tough, right? Because you know as well as anybody, I would think, that you just may not know. If you go back to 1970, there's a plasma cell that we can fiddle around with to make it make one type of antibody. Why would anybody want to do that? Cut. And then it turns out 50 years later, it ends up helping to save the life of President Trump. So I think, what's it like for you in this position to be making those kind of, life and death decisions now?
Luckily, I have an extraordinarily talented group of people, probably the most talented people who have ever worked at NIH. Jay Bhattacharya, who was at Stanford, Marty McCary, who's running FDA, who came to us from Johns Hopkins. These are among the top researchers and doctors in the world.
So those are the people you're going to be talking with? Who are you talking with?
I talk with them every day. I talk with them every day, and they share my aspirations and President Trump's aspirations that we want to do. We want to make sure that America remains the hub of scientific research in the world.
And yet, I've been up to some of these universities, and there are people who are worried about brain drain. They're saying, look, it's tough enough to be a researcher. I'm out of here. I'm not. And even people in high school and college are saying, you know what? It's too tough. I don't know what's going to be funded. I'm out of here. And so people are really worried about brain drain.
I don't think anybody who's doing good research has anything to worry about.
And who's deciding what's good research?
Well, at this point, it's going to be Jay Bhattacharya and Matt Mamoli, who's the top flu researcher at NIH, is going to be running NIAID.
And were they involved in the cuts that were already made, those more than 50 pages of those cuts?
A lot of the cuts were made by DOJ.
Yeah.
They were cuts that targeted specific areas. As I said, I have to look into these. I know some research got cut that we didn't want to get done, and we've been able to restore it. But most of it, virtually all the cuts were DEI cuts.
Got it. You've been a rabble-rouser your whole life. From the outside, what's it like to be on the inside now?
It's good. I mean, it's the best job I've ever had. I look forward to going to work every day. I'm working with immensely talented people, and as you probably know, the greatest joy of going to work every day is if you are mission oriented and you're working with exceptional people, and I have that privilege.
I know I'm running out of time, so I'm going to say, if you could change one thing about the pharmaceutical industry, what would it be?
I think what we need to do is to realign our incentives in this country. At this point, pharmaceutical drugs are the third biggest killer of Americans, and so pharma has given us extraordinary inventions and extraordinary medical treatments. But the profit orientation of the industry has sometimes given us also perverse outcomes, and outcomes that we need to do everything that we can to guard against. And what we are trying to do, our overall objective, is to realign the incentives for the industry, for hospitals, for the entire medical establishment with our public needs, which is to make America healthier again.
In 1960, when your uncle was president, 13% of American adults were obese. And as you well know, that number is up to about 42% or something like that. And so you have this problem of you wanting to make America healthy again, so creating an environment where the young people come into a much better environment and they don't become obese. But you also have all of these millions of people who already are obese. And we know that the GLP-1 agonists, for example, are really the most effective way of treating them. So I know, so what are you going to do in terms of coverage of the GLP-1 agonist for people on Medicaid and Medicare? Because you have to simultaneously have the next generation come in and be healthy, but also you can't just ignore the people who it's really the best thing to do to decrease their risk of dying prematurely and getting diabetes and everything else.
You know what? GLP agonists, which are extraordinary drugs,
Aren't they?
are available to anybody who's got diabetes. So anybody who's diagnosed as diabetic or pre-diabetic are entitled to that drug.
But obesity. What about obesity?
And for morbidly obese, it would be
For people
available.
over 30, I think it's over BMI of 27 with some heart risk, and then over
we're
30.
We're looking at a regulatory framework for making it available to people under insurance. It will be available to anybody who wants to pay for it. We are reducing the cost. We're going to reduce the cost.
Will Medicaid and Medicare cover it?
Well, let me finish in telling you what our blueprint is. Ideally, over the long term, we'd like to see that those drugs available for people after they try other interventions.
Okay.
So glucose monitors, for example, which are very, very effective and only cost $80 a month. And they've been shown to be extraordinarily effective in helping people lose weight and avoid diabetes. Health regimens, including particularly change in diet, but also exercise. So
Which, of course, have been tried for half a century.
Well, yeah, but now we have ways of monitoring it
results.
so that people can monitor themselves and they can show that they've done these interventions. If they don't work, then you would be entitled to the drug.
So if they don't work,
the framework that
that's news also to me. So if that doesn't work and a caregiver, a health care provider says, you know what, give it a good try, Medicare and Medicaid will cover the GLP-1.
That is the framework that we're now debating.
You know, I read last night.
And as you know, I mean, if you just made it, I mean, you know, I think everybody would like to make those drugs available to everybody under Medicaid and Medicare, but the impact on our medical costs would increase dramatically. And, you know, one of the estimates I saw is that the average employer in this country would end up paying double what they're paying now for healthcare costs for their workers, and that if we made the GLPs just generally
although in Europe they're 1/3 the cost of the United States, right?
They're less than that. You know, it's $1,300 here, the list price.
Yeah.
And in London, it's $88 for the same drug. So, and President Trump has ordered us to get to bring it down to you know, something around European pricing.
I'm getting this, meaning wrap up. I'm going to give you one last question, which is basic question. What's the basic level of care every American should receive, and who should pay for it?
Well, you know, that's when it comes to health care, that's a difficult question because people have a choice about how sick they're going to be, many people. If you don't have any choice, then, you know, then we should give you all the resources that you want. But I mean, it's a moral question too, and it's a philosophical question. If you're smoking 3 packs of cigarettes a day, should you expect society to pay when you get sick?
Maybe pay for you to help stop smoking.
Or should we encourage people? Should we incentivize people to take care of themselves? And then when they get sick, make sure they're taken care of. Shouldn't we build in some incentives for people to actually self-care so that they save, so they benefit society? It's the patriotic thing to do. It's a sensible thing to do, and it will help everybody. And really, and that's all about realigning our incentive system so people have an incentive to keep themselves healthy, and so that the industry has an incentive to actually look at outcomes rather than, you know, amplifying the number of tests that they do. And
So if somebody's trying as hard as they can, they're just doing everything, but they still are not sort of getting there, is there a certain
society should take care of them in that case?
And of course, the questions be, well, who decides that they've tried everything they can, and who would that be? The person who decides.
Well, I mean, there's a million ways to make that decision, and the way insurance industry used to do it is they'd say, "Are you a smoker?" And if you were a smoker, the price of your insurance would go up.
Yeah.
Oh, there were built-in incentives, and if you have private industry that is looking at actuarial charts and is looking at has an incentive to look at our behavior and to encourage us to take better care of ourselves, that's one way to do it. And what we're trying to figure out is how do you do it under the current system where there is no penalty for bad behavior, for destructive behavior. And if you want to eat donuts all day or, and drink sodas, that's your choice. We live in America, and God bless you can make that choice, and I would never take that away from somebody. But in terms of, should you then expect society to care for you when you predictably get very sick at the same level as somebody who is born with a congenital illness? And, these are all moral questions, they're philosophical questions. But they're also pragmatic questions that we need to be thinking about and we need to be answering. And the way to do that, the best answer to that is to realign our incentives so that the economic incentives to individuals and to industry align with the public health outcomes that we desire.
Well, that leaves us ending on Albert Lee, Minnesota, right? One of the Blue Zone creations. Have you heard about this, Dan Buettner?
No.
So Albert Lee, Minnesota, he tried to, about the Blue Zones, of course.
Yeah, of course.
And he tried to recreate it in Albert Lee, Minnesota. And he talked to the chefs, and he talked to the mayor, and they made new walkways where people could go, and they made the whole place healthier. And it was remarkable. In a couple of years, they had extended people's predicted lifespan. People were healthier. And that was by creating an environment where you didn't have to make a choice. Like in Sardinia, people are healthy because guess what? Every morning, the church is at the top of the hill. They got to walk up the hill and then walk down the hill. So the idea is to make an environment where you just trip over good health. The food is good. There's no other choices. You have to walk from one place to place. And I wonder how you scale something like that.
And that is exactly the mission that we're working toward now.
Is it really?
Is how do you, there are many businesses in our country that have adopted those kind of protocols. The Cleveland Clinic has done an extraordinary job at that in the study of its own workers. But there are many other industries that have said, if you work here and you do certain things to take care of your health, there'll be advantages for you in this job, and their healthcare costs have declined dramatically, and their lost work days have declined dramatically, and they have a happier workforce. So, I think what we're trying to do is to create incentives for a win-win situation where where people who are needy are taken care of, and where everybody is encouraged to take care of themselves and keep themselves healthy.
And not just incentives, but build an environment where they just trip over good health.
Of course.
Thank you so much for all your time.
Thank you very much for having me.
Mr. Secretary, I really appreciate it.